So I'll just stand by. Okay, great. Are you guys hot for me to get started? Just gonna wait. Oh, okay. Yeah, there's still kind of our. When did you get in last night? Hi there. Okay. Alrighty. Hello there. Can you guys hear me okay? Thanks. My name's Jenny, and welcome to, this is the BPAN Families Clinical Group meeting. I'm going to introduce everyone here on the panel. We have Dr. Adang, Assistant Professor of Child Neurology. And we have Dr. Emmerich. Thank you. We have Dr. Emmerich, Assistant Professor, Pediatric Neurology. We have Dr. Gregory, Genetic Counselor at OHSU. We have Dr. Hayflick, Professor and Chair of Molecular and Medical Genetics again at OHSU. And then we have Dr. Wilson, Associate Professor of Pediatric Neurology. And that is everyone. I'm going to hand this over to them, and then I will be on standby as you need me. Welcome.
Thank you, Allison. It's really great to see you all here. I know many of you, but I don't know you all. And if you haven't met me before, I hope you'll come up and introduce yourself. And I would love to have a chance to meet you and hear a little bit about your family and answer. We're always happy to answer questions. So some of us are leaving Saturday. Most of us will be around. Penny and I certainly will be around through Sunday. And so there's plenty of time to ask questions if you don't get your questions answered here, or if you want to ask a question that's specific to your child. It's usually better to do that, to do that in a one-on-one session. So just grab us at a lunch or picnic or dance or whenever, and we can answer your individual questions. You guys have taken over the NBI disorders community in a very good way. One of the things that's been exciting for me to see is, first of all, the growth in the organization and in the community, but also many of you are young parents of young children, and you come with such good energy that it's actually been it's really a valuable resource that we as a community need. And so I just want to express my gratitude to all of you for your contributions, individual, to the community, to the organization, to the field. We're partners in what we do here, and we really appreciate you. So that's my start. Penny just walked in. She's the other old lady up here. Penny's a movement disorders neurologist at Oregon Health and Science University also, and somebody I would say I recruited, maybe not. I recruited about 25 years ago now, 23 years ago, to begin working on the NBIA disorders, and she's been invaluable because I am not a neurologist, I'm a geneticist, and she's been really helpful in, particularly actually in the BPAN gene discovery. I wanted to start off, so you guys contributed a lot of questions, awesome, and we've got them organized, and Allison's gonna run that part of things, but we thought it might be beneficial if we started with a little bit of a kind of an explanation of my current thinking. So some of this is my own view about the sort of how the disease, what's causing the disease, how the disease progresses, and how we are thinking about BPAN at this stage. And when I talk about BPAN, I want to acknowledge that it's a really variable disorder. It affects people differently. It affects different people differently. And you all can look around and see similarities in your loved ones with BPAN from other people in the room. But you also will see, in some cases, pretty stark differences. And so what's true for one family may not be true for other families. And that's maybe where we can help you with understanding BPAN in your family, but we're going to do that kind of separately. The general sort of global understanding of the disorder, it's due to a mutation in this gene that sits on the X chromosome. And the contributing factors to that variability are the misspelling in the gene, the timing of the misspelling. Was it there in the egg or sperm from the beginning, or did it happen after a couple of cell divisions in the forming embryo? Whether the person has a second X chromosome, that is, whether the person's female or male. And then if the person is female with BPAN, women have two X chromosomes, and each cell in our bodies quiets one down, inactivates one of those X chromosomes. And in BPAN, it's not always a 50-50 chance which one gets inactivated, and that pattern of inactivation can also contribute to how BPAN manifests in an individual. So it starts with the gene. The gene is an instruction to the cells in the body to tell the cells how to make a protein. It's a blueprint, it's a set of instructions. And those instructions are misspelled, right? So imagine building a house and they've left out a couple of joists, or whatever your analogy you want to make. There's something incorrect in the spelling of the gene, and it causes the formation of a protein that can't do its job in a typical way, in a full and complete way. What our best understanding today about the role of the protein, the BPAN protein called WDR45 or beta propeller protein, the best understanding of the function of that protein is that it helps the cell recycle its own components. So cells are efficient, like a well-functioning household, and recycles the things that it can reuse, and sends away the waste that it can't reuse. And if you have a problem with that recycling system, as you do in BPAN, it causes damage to cells. Cells aren't able to manage their waste or their recycling needs properly. And that isn't a problem for most of the cells in your body, but it is a problem for brain cells, because brain cells don't replace themselves as a general rule. They're largely the ones that are there when you're a young child are largely the ones that are there when you're an older person. BPAN starts very, very early. It starts as soon as that mutation is there. The way that the brain forms is different from the beginning. So the wiring is different, the connections are different, the structure is a little bit different, the development, the maturation of the brain is different in BPAN, and all of those things contribute to a person who is born with BPAN and oftentimes shows in their first number of years, shows differences. They show differences in the way they develop, differences in language development, a tendency for seizures in many people with BPAN, but not all. So the brain is kind of electrically different. And then the sort of kind of ongoing changes, the autism that is common in people with BPAN is a function of this recycling difference and the development difference, right? So it's not something that suddenly happens when they're 4 or 5. It's something that has been there since they were a 2-cell or 4-cell or however many cell person. The degeneration that happens later in BPAN, adolescence, early, midlife, depending on the individual, is probably happening at a cell stage for many, many years before it manifests, before it shows itself. So there's sort of slow, steady, invisible damage to the cells in your brain if you have BPAN for many years, maybe many decades, before you show the difficulties with movement, the Parkinsonism that comes on in BPAN. And then in some very recent work that we've done It's building on the work of others. And it's actually something that is only possible from studying human brains from people with BPAN. There are these incredibly precious, tender gifts of families who have made the decision to donate their loved ones' brains after they've died. We've had a chance to study those brains, something we can't do in other animals because they're not human brains. They don't teach us the same things. And they show us a little bit about what that recycling defect does. And what we're seeing is an accumulation of certain proteins that are also seen in other diseases. So we do see a little bit of accumulation of the protein that is commonly accumulating in Parkinson disease, like you might expect. It's a protein called synuclein. But that synuclein is not the main story. And that's been the kind of eye-opening finding, I would say, and very, very recent finding. The main story looks like it's a different protein. It's a protein called tau, T-A-U, tau. You might have heard of tau. Tau is something that those of us in medicine associate with Alzheimer's disease, not Parkinson's disease. You can get tau in some sort of weird, atypical kinds of Parkinson's disease, but tau is much more commonly thought of as an Alzheimer's disease. But we don't really think of our family members with BPAN as getting Alzheimer's disease. But what seems to be happening is that tau is accumulating, and that is probably also contributing to the accumulation of synuclein, which is the sort of evidence for some Parkinson changes. So the reason I'm telling you that is that it raises in me the question of, well, what can we do to prevent, we've made our peace with this beautiful person who's in our life. They're happy, they're healthy, they're different, but we love them dearly, but we're super worried about this thing that's going to happen when they're 20, 30, 40, maybe earlier. It makes me think a little differently, that it's not just the Parkinson decline that we're targeting. That's important. It's important for us to think about. But there almost certainly is, if we were able to prevent the Parkinsonian changes, I think we would be seeing other serious neurodegenerative changes in people with BPAN as they got on in years. And so it changes the focus away, in my mind, from just trying to prevent the Parkinsonism to trying to think about a whole brain approach that can lessen the neurodegeneration. And that reminds me to talk about, you've noticed that I haven't said the word iron yet. I've sort of skirted over the iron because for me, even though we're the NBIA disorders and we're thought of as the brain iron people, iron is almost always a side conversation. It's never been the focus of my own research. We've never targeted therapeutics. We've never thought about targeting therapeutics for the iron because the iron is a side story. It's a side dish. The real story is the recycling defect in BPAN and in the other NBIA disorders for the most part. There are a few where the iron is more central, but not the ones we're here today to talk about. And so preventing the iron from accumulating or removing the iron after it's accumulated, I believe, is unlikely to have much of an effect, if any effect, and potentially is a problem to try and remove it. So there was a very recent study in Parkinson's disease where the people with typical Parkinson's disease were given deferoprone, and it was quite a well-controlled study and done over a pretty short number of months. I think it was 3 months or 4 months, and they got worse on iron chelation. So we know that iron accumulates in Parkinson's disease. This is the first evidence I've seen where they got worse. They got clinically worse on chelation. And so I don't consider chelation to be a neutral intervention. It may have benefit in BPAN that we don't know. It may do nothing, and it may make things worse. We don't know. There may be a role for doing a clinical trial to answer those questions, and that may well be worth doing. That's not a trial that my team would choose to lead, because we're focused on the recycling defect. We want to solve the problem at its origin, not take care of the downstream problems that we don't think are central to the disease itself. So I thought it would be helpful to just kind of give that framework so that you understand how we're thinking about things. If you talk to other doctors, they may have different views about things, and I'm fully open to the possibility that I'm wrong about some of the things, but it's this new insight into the tau protein that has got us thinking more about, we can't just target the Parkinson disease and try and just treat that part of the brain. Almost certainly we're going to be seeing other changes in those individuals, and my guess is pretty soon on the heels of the Parkinson changes. So with that, I'm going to take a seat with the gang and turn things over to Allison.
Thank you. So you all submitted an impressive number of questions, things that you would like for us to address today. Over 100 probably. So what I'm going to try to do, what I've done is I've looked at all those questions, I've sort of identified themes, repeats, things that are maybe relevant to the whole group versus to a small number. So I'm going to ask some questions of the panel that I think will be interesting for everybody and be useful. And then I think, this is also supposed to be interactive. It's okay if, if there's a follow-up question, raise your hand. And then at the end, we'll leave some time for more live questions if some of you didn't have time to submit things, if that sounds okay. So I'm going to start with more the pediatric end of the table here, and maybe Dr. Wilson can be the first one to comment on this or kind of orient us. But there were a lot of questions about language. So what causes the specific and disproportionate effect on expressive language? So Jenny, maybe you could kind of describe what you've seen with language and talk about what you think about that.
Yeah, so I think BPAN, just closer, okay, is not totally unique in this. A lot of neurodevelopmental disorders, expressive language is one of the areas that's most impacted. I think a lot of different things have to come together to make expressive language work. So I don't know exactly why it's particularly a challenge in people with BPAN, but it does seem to be an area where many individuals develop a little bit of language, but not a lot. But there is a wide spectrum, and there are people who, have a lot of language, spoken language that they use. And there's a broader discussion about just communication in general, which, but I think the question's about expressive spoken language. So yeah, I think there are a lot of different pieces that come together. Like there's a motor piece, there's a how do I make my face do this? There are a lot of different areas in the brain that kind of have to connect appropriately. So I think it's just a more complicated process than some of our other functions, which makes it a challenge.
So I trained in neurodevelopmental disabilities. I'm going to give a little shout out to the NDD world too, because it's a subspecialty that's neuro and development. And I think it lends itself to this community very well. It's because thinking about the developing brain, like you say, and like Dr. Hayflick was also saying, when the brain it's a developing brain. So like she said, so in BPAN, the genetic change is there, and it's there from the entire time. So as the brain is continuing to develop, how do we try to help that development? And I think one of the questions they're going to talk about too, so there's two things, right? So sometimes people wonder, if I'm having a lot of seizures or other things, is that going to impact my speech later? And how well do we control that? And again, you're going to find a lot of us saying we don't know, but we're interested in looking, I think is a big thing. But then we talk about apraxia. So apraxia, I think people probably have heard quite a bit of apraxia, right? Apraxia, in my opinion, I feel like speech pathologists talk about apraxia and neurologists talk about expressive language. And it can be different things like Jenny was just saying. there's the motor piece, and sometimes is it motor or is it more the connective? And it's the connection pieces. And I think that's what they tend to feel a little bit more when the speech pathologists talk about the apraxia, about the connections of being able to, kind of make that language and produce the language in and out. I think one thing that I think is interesting that I often find too, and in my training, is if we're thinking about children, if they don't have a lot of expressive communication that they come out, one of my training, we talked about the internal language that we have that oftentimes in ourselves, if you think about how much language we use in our head to calm ourselves and to help ourselves. And so I think a lot of the children I see with BPAN and other conditions where language, expressive language in particular, is impaired, often have a lot of anxiety and need structure and other things to help with their behavior again too. So it all kind of comes together for, I think, when we think about a lot of these questions, how we can't fix one piece. We're trying to fix one piece to fix other things, but everything is interconnected as well. And for us to try to learn about those connections, but it is different in every child as well.
Well, just more on communication that while expressive speech is a big challenge, that individuals with BPAN have the ability to communicate in many, many different ways. And I'm sure many of you are experiencing this, but maybe not everybody, that there are some great experts out there in what's called augmentative communication, and it's a way to really tap into your child's inner thought process in ways other than using expressive speech, and it can be really eye-opening and I guess a big game changer for some parents. So finding those specialists, I think, is super important.
We're wondering if there's an augmentative communication person at the conference. I'm not sure. Yeah. Friday. Okay, Friday. So there were also a lot of questions submitted about seizures, and we could do a whole hour-and-a-half session just on seizures, I'm sure, but I tried to kind of drill down to some of the issues. So maybe Laura and Penny can talk to us a little bit about their thoughts on this. But one of the really interesting questions was, many kids with BPAN appear to have seizure-like episodes, and these episodes might be interruptible, or they might not register on an EEG. I think we hear from families all the time, well, we're not sure if that's a seizure, or it changes over time and eventually becomes clearly a seizure. So are these seizures? What's their significance? What are they telling us? Maybe you can talk about that.
Hello, my name is Laura Adang. I'm a child neurologist at the Children's Hospital of Philadelphia. I am not an epileptologist, but I'm happy to talk on this. I think it's a challenge, and so when I meet a family and they're concerned about seizures, you take it seriously. The best way to determine if it's a seizure or not a seizure is to be able to capture it in the moment with something called an electroencephalogram, or EEG. The challenge with that is if you don't capture the event of interest, it may not actually be incredibly helpful. Many children affected by BPAN have abnormal EEGs at baseline, meaning if I don't capture the event, the rhythm isn't a typical rhythm. And that makes it really difficult unless we capture what you wanted to know to really determine it. I think it's very similar to our Rett syndrome population, where children can have a lot of movements at night, and sometimes they are seizures and sometimes they're not. And so I take it very seriously, because I think there is both a high risk in both directions, right? We know the rates of seizures in young children can be as high as 80% of our population. And so it's something that is a very real risk, but there are a lot of other things that can disrupt sleep or be a nocturnal or kind of interrupting activity. Many of our children have profound attention issues, and so you zone out and it looks like a seizure. In those cases, I ask families to take a video of it. The other thing I really like to do is gently have the parents blow into the eyes. If you blink, that causes it's a corneal response. It's much less likely to be seizures. And these little things that help us figure out if it's seizure or not seizure can really help us avoid when we don't need a medication. I know it may not seem like it, but as doctors, we really don't want to treat things right? You will be on a seizure medication forever for something that may or may not be an actual seizure, and that's horrible, right? And so our goal is really to be truthful and figure out if it's a real seizure or not. If it's the same type of event every time, those are the times I don't go and reinvestigate it. If I've already captured it, I have a definitive answer. But I do open the book up again if it's evolved or changed over time, because sometimes time tells us the story of how we need to treat it. Children can also have things like autonomic dysfunction, where they can flush, they can become a little bit less attentive. Those can happen at day or night. They can look like seizures as well. Children can have tonic spasms of their arms and legs from the stiffness. So there are many, many things on our list of possibilities when a family comes to us and they're worried about seizures, all of which have a completely different treatment pathway. So my general approach is to take it seriously. First, look at the things I'm most worried about, and then go down the list and identify what's actually causing these spells, so we can help families in the right way, rather than just calling everything a seizure, because honestly, most of it probably isn't. So hopefully that was helpful. Let me pass it down to another neurologist.
One thing I would just say, so for those of you, particularly those of you that are newer to the diagnosis, one thing that I hope has come through kind of in the community, but I want to say loud and clear, is for most children with BPAN who have seizures, even sometimes quite severe seizures, those seizures tend to abate or become much less of a problem in later teenage years, mid to late teenage years and adulthood. And, you know, sometimes I think that that's lost kind of in the anxiety around diagnosis. There's not a big discussion about it, but this can be all-consuming when you have a child who has a really troublesome seizure disorder and you're going through, you know, different medication trials, and they still are having seizures that are captured and are real and are having an enormous impact on the child's life and on your life as a family. There's this sort of kernel of optimism that in almost all cases they tend to become much less severe and often to go away completely in teenage years and adulthood. So just to make that point.
And I don't know how often, so I'm here in Houston, and we have the luxury now of being able to do home EEGs, ambulatory EEGs, which again, in theory, sounds nice, but I also recognize sometimes it can be hard, right? Because the child essentially has this big thing on their head and wrapped around and walking around, but it can be helpful, and I feel like hopefully most of the companies that are able to do this do work with children who have behavioral or developmental impairments, so try to be mindful, but it can try to be as much information as you can at times, but sometimes we don't have that luxury, so right, it's trial and error and communication.
Okay. In case you hadn't noticed, I've kind of grouped these questions, so we're sort of in the clinical arena right now, but we'll hop around too. But I'm going to ask Susan to start with this one. It's sort of a more global question. I'm sure you've all noticed that there are more girls in the room with BPAN than boys, and this sort of gets at that. But this parent said, boys with BPAN are exceedingly rare. How should we as parents of a BPAN boy think about the various studies and stats, as most of what we know is based on girls? Should we think about boys differently? What do we need to know if we have a son with BPAN?
Yeah, that's a great question. So boys with BPAN span a spectrum. So there are boys who are at the very severe end with really kind of striking changes as newborn babies. And then there are boys who aren't diagnosed until they're in their, a couple of years old, and they actually look, in terms of their features, they look a lot like sort of a typical girl with BPAN. And so there's quite a broad spectrum, and that kind of comes down to your genetics, like I was talking about at the very beginning. I guess I would say, depending on where a son, a brother falls into that spectrum, you can kind of pull, because everybody, whether you're a boy or a girl with BPAN, every family is trying to pull what's relevant from the sort of bulk information that we're sharing and understand, well, is that relevant to my child? My child never had seizures. Why didn't they have seizures? So it maybe helps you put your child somewhere on the spectrum of severity. Sometimes it's helpful to find other families who have kids who are kind of similarly affected and kind of to talk shop with them, because you are the experts on that narrow kind of slice of the BPAN set of features, what we call the BPAN phenotype. And so depending on where the son falls, I would say if they're at the more severe end, I think most of what we say about BPAN is true for those individuals, with seizures and difficulty with communication, but not necessarily. So I guess, we're interested in talking to you one-on-one if you have a question about your own child outside of this group meeting.
Yeah, so there's something in medicine called anchoring bias. We think we know what a disorder is or how it affects people because that's exactly what we had seen before. Anchoring bias helps us in medicine, right? It helps us make faster diagnoses. But the other thing it does is it narrows our view of how something like BPAN affects people. And as we're starting to move towards more broad-based testing, and we're not just looking for things like iron accumulation in the brain, we're realizing that things like BPAN are affecting families in an incredibly varied way. At our BPAN clinic at CHOP, we have around, what are we at, Dr. Thakur? Probably around a quarter of our patients are boys. It's because they've been picked up through non-traditional ways. Right? And so when you start doing more agnostic testing, meaning broad-based testing, we're going to be expanding the spectrum together as a community in figuring out where the boys fit in relationship, both with the goals for clinical trials, for clinical care. We are in a place of exciting movement as a community as we are redefining what it looks like to have these disorders and trying to get rid of our anchoring biases that BPAN only affects girls. They all have Parkinsonism later in life. I think we are going to be wrong in many of our early assumptions because that's all we saw. And it's really exciting to see this field change and evolve. So to the parents of boys affected by BPAN, we hear you. we realize it's a really large population that has just not been traditionally diagnosed. And we're excited to see how we can adapt and modify the field to fit everyone's needs because we realize it's much, much more diverse than we had originally anticipated.
Yeah, that's really helpful, thank you. And I think there's another term we use, which is called phenotype expansion. And what that describes, and I think you've all experienced, is when we very first found the BPAN gene 10 years ago, we found it in, 13 or 14 patients who were incredibly similar and incredibly alike in their age and their symptoms. And that's, we needed them to be similar like that to find the gene. But then once you've started testing more broadly, like Laura said, well, then there's this expansion, and all of a sudden we're shocked because we saw this new thing, and we're diagnosing them younger, and we never saw a toddler with BPAN. So we're still in that phase, I would say, of this expansion and explosion in our understanding about all of this, and you helped teach us on that as well. So in discussing the seizures, Laura had also mentioned something called dysautonomia, and I just wanted to turn back to that for a minute because there were questions about that as well, and I think because it can manifest or show itself in different ways, it might be helpful to have a little description of that, but because I'm in the Facebook group, I see pictures of, purple cold hands and feet a lot, and people asking about this, and is this BPAN, and why? So I'm not sure who might be comfortable talking about dysautonomia, if a few of you would like to address that. I guess it's Jenny.
Oh gosh, yeah, I think this is kind of an understudied area, to be honest. We see this a lot in BPAN and in other conditions, other neurologic conditions like cerebral palsy. And basically the autonomic nervous system controls some of these automatic functions like your blood vessel regulation, your bladder, your bowels, lots of other things. And so those get a bit dysregulated with BPAN, and kids can have, as Allison was saying, like discoloration or coldness of the extremities, and urinary issues and bowel issues. We don't have a great understanding of why this happens, and two, we don't have fantastic treatments. And it's not clear that we need to be treating this necessarily. I think it's important to think about, okay, well, is this symptom bothersome or not? I think parents worry a lot seeing discoloration, and I often have this sense that maybe they're not getting good blood flow and that there's a risk to the limb, that they might have a serious problem from that, but that's not what we see. We don't see any serious or dangerous problems with that. It's more about keeping the child comfortable if it's bothersome than using measures like, gloves or just doing something with environmental. We don't have to do anything to treat that. Some of the other kind of autonomic symptoms like bowel and bladder symptoms can be a little bit more troubling, and we do have treatments to address that, but I think this is an area that still needs a lot of exploration in the medical community.
So, so I want to pose this question, right? So we think about autonomic dysfunction, and like you say, like I think the blood flow, so what helps blood flow? So we have a specialist who we test iron, right? So it's kind of interesting in this population, right? So iron, vitamin D, CBC, and fluids. So if your iron is low in these children, would you recommend iron supplementation? And I think that's the important piece, because I think everyone, like a lot of times, I think I've posed that too, and I'm like, right, because of course, right, if you need it, it's not going to make your condition worse. But I feel like I've had some other people who get afraid about that, but it can help and just increase fluid sometimes. And then some of the anti-epileptics can also make you a little more acidotic, can make you a little more dehydrated, or you're sweating as well. So it's important to know too, the medications might also have impacts on that as well.
Katie.
You're talking about the extremities, which we've seen, but can blue lips be also part of?
So if you can't hear in the back, someone's asking about whether blue lips could be part of that or more reason for concern.
Yes. The blood vessels around your lips are by far the most superficial of your body, and so they are the most adaptive to when blood is going elsewhere. And the autonomic system helps shuttle your blood from one place to another, right, by squeezing your blood vessels. So absolutely, it can be a sign of autonomic dysfunction. I've also seen a lot of flushing of the face, and sometimes, strangely, just one side of the face, right? It doesn't have to be a symmetric thing. I will do a shout out to seizures. Blue around the lips plus staring spells raises my hackles for seizures. So I would just want to make sure because we don't do the same interventions for autonomic instability, it is on my differential when I'm concerned about seizures. So I would just want to make sure we were quite certain it didn't need a different style of treatment.
Once I see you, just one sec. And when you mentioned flushing, I mean, I see a lot of parents in the Facebook group too with posting pictures of various different flushing and rashes, not just on their face, but chest, extremities. I mean, is that likely dysautonomic as well?
Yeah, I think, as Jenny alluded to, I think despite the fact it being the most primitive or kind of original part of the nervous system, we understand the least about it. And actually, what is causing the dysfunction, we see it across a very wide range of neurodevelopmental disorders, and we don't have good targeted treatments. So yes, it can cause blood pressure changes, heart rate changes, flushing, sweating, temperature, very high temperatures, very low temperatures, and it can be both persistent, meaning kind of ongoing issues, or it can even be changes that happen moment to moment.
Then there was one more follow-up right here.
Yeah, I just had a question on the opposite end, like the temperature regulation in like a hot environment. So, yeah, can you speak to that at all? With, like you said, with heat and flushing, but I mean, is that a concern when you're in an excessively hot environment with their temperature regulation?
Yeah, so I think the question was, how much do we need to control the temperature? I think at nighttime when kids are sleeping, even on a cold day, kids will get overheated, and so a lot of families have their fans on at night. I think that's fine. Is there a danger about getting overheated at, when you're going out to, say, Disney World or something, and it's a really hot day? I mean, I usually say just listen to your child's comfort zone. And I'm multiple sclerosis trained originally, and there's a lot of really helpful tips and trades that the MS community has developed, including things like cooling neck bands and things like that that can be incredibly helpful to help your child stay comfortable. So I think it's less that they're hot on a hot day, it's much more that they would be really uncomfortable from being hot on a hot day.
But again, so if you're on zonisamide or topiramate, right, you might not sweat as much, and therefore you need more fluids as well if you can. So again, those are certain seizure medicines that you should also just be aware in conjunction with those same sort of symptoms.
So following on from that, for those of you that have a young or older adult with BPAN in your family, I think once somebody sort of moves into, or if they move into that phase where their picture is really changing in a big way, I think they can have autonomic problems that are a little different in flavor. And there, I do think temperature regulation becomes a bigger problem, and it is sometimes related to Parkinson's medicines that they get put onto. There are a number of medicines in the Parkinson's family that can impair sweating, and then independently, the actual sort of disease process at that stage of BPAN, later in BPAN, if people have Parkinson's-like symptoms, I think they can have a lot of trouble regulating blood pressure and temperature. If you drop your blood pressure, sometimes that goes along with trouble regulating your temperature as well, a lot of trouble in hot environments. But it's a bit of a different challenge, I think, than we're seeing in childhood. And so I don't want to imply that it's all the same thing at all. Can answer questions for families who have an adult with BPAN, maybe offline if they've got questions about that.
That was actually a great segue, so hang on to the mic there, Penny. Sorry.
This is a bit like, musical chairs. This is musical microphones, right?
So because there are a lot of adults with BPAN at the meeting, and there were some questions about this, I think what people describe maybe as mood swings or changes in mood or behavior in adults, the screaming and you don't know why, vocalizing some of those things, why and how do you help them stabilize or maybe help treat some of that?
So that's a tough one because we'd love to be able to drill into, so what exactly is happening? I think, again, this is where your participation in the natural history study and us getting sort of a picture from as many people as possible about the course of BPAN, which is enormously variable, because of this phenotypic expansion and anchoring bias, these terms. So we're learning all the time, and it is from you. I think there's a few things that could be coming into play here. So I think, and I don't want you to run with this too far, but I think if somebody is having more trouble cognitively than they have had, I think sometimes it can make it harder for them to make sense of their world in the same way that they've always been able to. Now that can apply to a child as well as an adult. Things change, and if you are intellectually disabled or differently abled as a child, it is, you need a lot of cueing and a lot of help to make sense of the world around you. And as you move into adulthood with BPAN, if you have some of that cognitive stuff start to play a bigger role, I think all of the tools that you have developed throughout childhood and early adulthood suddenly become a bit more challenging. And so some of the behavioral, I'm using that term loosely, but some of the screaming fits and changes in behavior and things that are really challenging for families, I think come about because of a change in cognition. And then I was going to say something else, and now it's gone out of my head. What was I going to say? It'll come back to me. And probably in the middle of you talking about something else. Yeah, so, again, medications are always are going to be a factor in everything, whether you're talking about seizure medications in childhood, whether you're talking about other medications that a kiddo might get put on. I mean, I'm sure many of you in this room have had the experience of there's a change in medication, and then suddenly your world, which was already a little on the edge, you got turned upside down, and you're like, what the heck is going on? And the child might get taken off, your kid might get taken off that medication, and suddenly things even out. But it's a rough road. I mean, it's a really bumpy road. Same thing can happen in adulthood, particularly if somebody is being started on Parkinson's type medications, which can be very helpful at a certain point. But they can come with some behavioral challenges too. And now I remembered the other thing I was going to say. So if somebody has Parkinson's as part of their Parkinson's-like symptoms, as part of their BPAN picture, if they've gone through some medication cycle and their Parkinson's type medication is wearing off, meaning it's getting to be time for the next dose, they can develop some discomfort that can cause agitation. So that balance of trying to sort of manage the timing of meds, particularly in people who have quite advanced disease with challenges there, that can be tough because you're trying to read the situation and know how to change the timing of meds to keep somebody comfortable. Usually becomes fairly apparent that it is physical discomfort that is causing the distress, but that can be hard to interpret at some points, I think.
I was like, do I have something to say? Well, I guess behavioral challenges, we kind of see across the lifespan in lots of different developmental disabilities, and just kind of some general thoughts would be if you have somebody who can analyze the situation a little bit from a kind of outside perspective, it's helpful to look at what's happening right before the behavior starts and what happens afterward, and take a look at that objectively and see what sort of patterns are there. Because oftentimes there can be some patterns, and there's room for intervention and changes if you can get that kind of expertise to take a look.
I was just going to add in to all those wonderful thoughts, a change in behavior, and that includes new onset autonomic dysfunction, new onset screaming and discomfort, needs a medical workup. And it could be just seeing your doctor who understands BPAN to get some ideas. In my world, a lot of times it's constipation or tone issues until proven otherwise. But it needs a workup. What if a kid has a urinary tract infection and that's why they're screaming and so upset? We know we get autonomic dysfunction affecting voiding and making you more likely to get a urinary tract infection. And if we chalk it up to the behavior issues we know we can see, then you're going to miss something that needs medical intervention. So I think my point is really constant behavior issues or steady behavior issues that have been stable over time can be managed with behavioral management, but something that is brand new to the child and is a new behavior really needs to be looked at really closely to make sure we're not missing something that has a treatment.
Yeah, I think kudos, because one of my most frustrating things is when people just say, in the outside community, the physician, it's disease progression. And these are people who don't know the disease. And I'm like, oh, really? You know there's so much, it's disease progression, but we have to think about things that are treatable, and an acute change needs to be addressed.
I think we have consensus on that one. Did you have a follow-up, Amber? So there's a behavior management session tomorrow that'll address some of the things that are behavior and have passed the medical workup. So I'm going to do a little shift to our medical geneticists down at the other end of the table. There were some questions submitted about gene therapies. So I'm wondering maybe, Susan, if you can just give us kind of an overview of your current understanding of where the BPAN research community is with gene therapy?
Yeah, I would be happy to do so. So there's a lot, so stepping away from BPAN and just talking about gene therapy in general. So there are some gene therapies approved by the FDA now for different genetic disorders, single gene disorders like BPAN. But what distinguishes those disorders from BPAN and many, many, many other disorders is the timing of diagnosis and the extent of involvement in the brain and spinal cord. So the question is, where do you need to get the genes in? So gene therapy is, what that means is you have a cargo, which is the gene, and you have a delivery system, which is a safe virus called an adeno-associated virus. It's a virus that is, does not cause any kind of health changes in humans. It's been used, it's quite safe. We use this virus as the delivery system for getting the genes into cells and then for the genes to be incorporated into the natural genetic material. In order to deliver genes to every cell in the brain, that is a mountain we have not been able to climb yet. So that is extensive delivery with a large dose of virus, and we aren't doing that yet in a successful way. I do think there's a lot of work being done on that, and a lot of interest in disorders that are whole brain disorders like BPAN. So that's kind of the high level for gene therapy. There's some really exciting work going on that's being led by the NIH. So your tax dollars at work, in something called, it's actually through the National Center for Advancing Translational Science, NCATS. And they are all about accelerating medicine development and including gene therapy. What they're trying to do, I've just described to you, the virus carries a cargo. Well, if you had the perfect virus to do that, and you had all of the regulatory, all the FDA business taken care of, why can't you just swap out any of the 1,000 or 5,000 or 10,000 genes that we need to use for gene therapy, right? You can use the PCAN gene, you could use the BPAN gene, you could use the MPAN gene. Why can't we just do it in a sort of modular system? And the NIH is thinking, oh, that sounds like a pretty good idea. Let's figure out a modular system, and they're working on that right now. And so it's kind of we're at the dawn of gene therapy, but it's going to be, blazing sunshine over the course of the next 5 to 10 years. We're going to see an incredible acceleration in new gene therapies, in approved gene therapies, and in better delivery systems to harder to reach parts of the body like the whole brain. It's my view that for BPAN to be treated with a gene therapy approach, you can't just go to the Parkinson part of the brain. You can't just go to the seizure part of the brain. In this case, who even knows where that is? You actually have to hit the whole brain. I believe you have to hit the whole brain. And that's, again, driven by this opportunity to study brains from people who have had BPAN, who have lived with BPAN, and to see that there is trouble almost everywhere. It's worse in some parts, but it's not localized to a small part. So having said all of that, there is work going on today in gene therapy. I may not know about all the work going on in gene therapy, but what I do know is that there's work going on in the UK, that they're working in cells, in nerve cells. So we can take a little bite of skin from you, and I notice we have, from a number of you. We can grow those skin cells, and we can actually turn those skin cells into what are called pluripotent stem cells. That means they become maybe infant or maybe embryo-like cells, and they can become anything we direct them to be. And we have the ability to de-differentiate them and then redifferentiate them so they become nerve cells. We can take your skin cells and make them into nerve cells, kind of like brain cells. And we can look at how gene therapy works in those cells. We can also make tiny brains in a dish, what's called an organoid. So we are cloning you. Yeah, that's the, I didn't want you to, I didn't want you to hear that part. We can make these organoids, which are kind of like brain, and we can use gene therapy to infect all of the cells in that organoid and see how that changes the development and the function of that clump of organized cells. So there's a lot of work going on. There's a lot of interest. I will say that there's a key thing that I think holds us back in the BPAN world for other kinds of therapeutics, not gene therapy, because all you have to know is the gene. For gene therapy, I think what's holding us back is the delivery system to whole brain. What's holding us back in terms of other therapeutics for BPAN is that we don't really totally know what that protein is doing. We think we do. We think we know most of what it's doing, but I'm going to bet that we don't know the whole story yet. And that's holding us back from understanding all of the ways that we could develop therapeutics. That's the kind of frustrating part for me. The really exciting part is that the day we found the BPAN gene, we didn't have to start to build a research community. There were already hundreds, maybe thousands of scientists around the world who were already studying that recycling system. It's called autophagy, A-U-T-O-P-H-A-G-Y, autophagy. They were already studying it before there was a BPAN, or before there was we associated the BPAN gene with the disease. And so they've been studying it all along, and they're working on the function of the protein. They're very interested in the function of the protein. So there's a lot of people working on this disease who may not kind of have sort of connected with the BPAN family community, but they're very, very interested in the process.
I have some questions for the community, and I don't expect any answers here, to be perfectly clear, but it's sort of issuing a challenge to you as a community to think about, to consider personally for yourself, and maybe to talk about as a community in the sort of social media network that you've impressively established. You are now the largest group under the NBIA umbrella. We would, I'd like to make a case for us sticking together, because I think we are only where we are because this started under the NBIA umbrella. Arguably, might not even know about the BPAN gene today if we had not been under that brain iron umbrella. We found the gene because we had a group of adults who had a very similar story. We didn't even really know whether this was a genetic disorder, to be honest, because they were all at the beginning, one person affected in a family. And it was only because of a grant that was not, disease specific, that allowed us to find the gene, that allowed this community to form, that allowed the research to move forward. So that's my plug for staying together. The other thing is I just sort of want you as a community to think about, we have, Susan has said, we're very focused in our group on the underlying basis of BPAN. How do we fix the underlying problem? And that's kind of a grand goal. It's the mountain that we want to climb. It's where we want to be. Is what we're driven towards. But there may be opportunities to do much smaller clinical trials that are looking at some of the kind of core questions in BPAN that are quality of life issues, that are like, what is the best approach to sleep problems in BPAN? What is the best approach to a certain subset of seizure problems? That's a tough one. But probably not going to do that study because it's so varied across folks. There's a lot of questions that we could be not only asking and studying, but potentially sort of small treatment trials that are not solving BPAN. They're not like putting you into a gene therapy trial, but your child into a gene therapy trial, but they may have very real value. You are an impressive, like stunningly impressive fundraising community as well. Power in numbers and power in community. You have the ability to fund research, you are funding research to help us as an organization direct research, to drive research directions. We are hearing you. We're trying to talk to people individually. We're trying to listen to the community. But I think there's a lot of opportunities. And so I'd encourage you to sort of think as a community, what would you like as a community in the near term and in the long term? I think all of us in the long term want to solve BPAN, and we want this not to be here for our child and for children in the future. You know, the tough thing is, as Susan said, BPAN's established by the time your child is born, and so we're already partway up that mountain that we got to climb, we got to catch up, and that's a tough thing, but there's huge opportunities here, and so think about it as a community.
I wanted to make one other point, which is I mentioned to you the risk that has now been recognized with chelation and Parkinson's disease, that, you know, it's always important to keep in mind that the things that we're doing in your family member, if we're doing something in your family member, some kind of an intervention, oftentimes we take sort of baby steps towards that because we don't want to do harm. That is sort of the basic tenet of anything we're doing. And sometimes we don't know whether we will do harm. We have to test the waters. You know, they tested the water in thousands of people with Parkinson's disease to find out that the chelation made them worse. When they stopped the chelation, did they get better? Did they get back to their baseline? I don't actually know the answer to that question. But recently I had a parent contact me, child with something unrelated to our group of diseases, but she had a question for me, and she was explaining to me that her child had just been in a trial. I don't remember if it was a gene therapy or a cell therapy trial. It was a brain trial, and that her daughter was precipitously worse after she had that therapy, and they actually stopped the trial after treating a couple of kids because they were seeing very serious problems. And after a child has had either a gene or a cell therapy, they often are not candidates for further trial participation. They may be candidates for the treatment eventually, but they often can't participate in other trials. And so it's really important to keep in mind, we're really careful about the steps that we take, but oftentimes we don't know risks when we're, you know, we explain these risks to you in very real terms when we're consenting you or for your child to participate in a study, but we don't know, and that's a genuine uncertainty.
Thank you. Susan, I'm going to ask you to circle back a little bit. So when you spoke in the beginning, you did mention iron and, you know, autophagy versus iron sort of being a side story. We had a lot of questions submitted about iron, so if we could just spend a little more time. These were questions about, do I need repeat MRIs? How do I prevent the iron from causing sort of this second deterioration in adulthood? You know, those sorts of questions.
Yeah, okay. So your loved one with BPAN should be on a normal, healthy diet, whatever diet works for them, and it should include a normal amount of iron. If they're iron deficient, as Lisa was saying, they should have supplemental iron, just like you would do for a child who doesn't have an NBIA disorder, because the brain in BPAN will steal as much iron as it's going to steal, whether you starve the person of iron or not. And if you starve them of iron, they're going to have a whole lot of other problems besides their BPAN. So they need iron in their diet. The brain changes. So again, as I said at the front end, iron is not the problem. It's not the main story. It may be contributing to disease that there is an accumulation of iron, but we don't know that. It may not be. It may be sitting there, not causing any problems. Taking it away might help. It might do nothing. It might do harm. We do not know. So my view is the iron is kind of it's collateral damage. It's a side story. And what we're learning in some of the neurodegenerative diseases is that the reason iron accumulates is because there's actually not enough useful iron. There's not enough bioavailable iron in the brain. And so the brain thinks it's iron, it doesn't have enough iron. And so it signals to the rest of the body, hey, send more up this way. And so the iron story is not the main story, but it's the easy thing to kind of help with understanding these diseases and oftentimes with diagnosing them, the MRI. We don't recommend MRI. We don't recommend following the iron by MRI. If your child needs an MRI for another reason, they should have one, but they should not have an MRI just to check their BPAN, because it doesn't tell us anything about their BPAN. Looking at the kid tells us something about their BPAN. You tell us something about their BPAN. We don't use the MRI to track it. What was the other question? Tracking it with imaging and... Yeah, so the iron also is not causing the Parkinsonian decline. The iron is a side story, and just like taking it out in Parkinson's disease was a bad idea, it might be a bad idea in BPAN. We just don't know. It might be a good idea, it might be neutral. We just don't know. The iron is not causing these problems. I think of it as kind of a result. One of the results is these proteins accumulate, tau, right? You guys aren't sweating tau today. You will be tonight, because you'll go home and you'll read about it, and you'll suddenly it'll become your thing. But your iron is the thing we all know about, and for better or worse, it's in the title of our disease group. But for none of the NBIA disorders is it the main story. It's always kind of a side effect, but it's useful in helping to get to a diagnosis oftentimes. Sometimes I get asked in the sort of academic community, will you talk to us about general disorders of brain iron, like Parkinson's, and how is iron relevant to Alzheimer's disease? And I write back to them and I say, I'm not really that interested in iron.
Remember that. So I'm going to pose one more question to the panel, and then just so we don't punish those of you who didn't submit questions ahead of time, I thought we'd open it up and I can, walk the mic around if some of you have burning questions with our last few minutes. But I did want to ask, and maybe several of you can address this. I mean, there were a whole slew of questions about other potential treatments or supplements like alpha lipoic acid, mito, cocktail spermidine that some people have seen about, buying online. Susan, I asked you about that one a month ago, I think. So if people have opinions or thoughts on the potential for that, maybe we could speak on it a minute. It's not a trick question.
I have a rule of thumb for trying things. My rule of thumb is this is for over-the-counter things, not for prescribed things. If they're over-the-counter, first of all, they may not be what they say they are. Really important to know. So there was a recent article in the New York Times about melatonin, and they tested 25 melatonin supplements. 23 of them didn't have what they said they had. So the amount that's in there might be different, might be wrong, and whether the stuff is even in there might be wrong. You can make a lot of money selling supplements. It doesn't matter what's in them, right? So do no harm. If you're interested in trying a supplement, do some research. Figure out whether you'd give that to, a healthy person, whether you feel like it's safe. As long as it's doing no harm or unlikely to do harm, try it. Try it at a low dose. Don't try other things at the same time. Try only one thing at a time. Get to the dose you're interested in trying. See how it's working or not working, and try and be kind of rigorous and challenging to yourself in whether it's making any kind of a difference. there's a long list of supplements that get tried in quote, mitochondrial disorders. Is BPAN a mitochondrial disorder? It's a little bit mitochondria and a little bit not mitochondria. It's more complicated than that, I think. But you could try alpha lipoic acid, thiamine, any of those sort of water-soluble, over-the-counter things. Again, do them one at a time and start at a low dose and creep up and see if you think it helps. We don't have any specific recommendations for or against those, but I try to support families who want to try things.
I would just make the point that harms or risks, so we're always weighing risk versus benefit. So, you know, Susan addressed kind of trying to assess the harms versus potential benefits, doing that in a systematic way. But harms come in many flavors. So the most obvious thing is, does it make your kid or yourself worse in some measurable way? You know, does it cause side effects that, you know, seem like they're problematic? But there's other kinds of harms. One is money, the pocketbook. This can cost a lot of money depending on who's selling those supplements and what they're comprised of. I mean, this can be an expensive exercise, and so I'd be mindful of that. And then things like, you know, if it's a horse pill that's this big and you have to give it 6 times a day and your kid is gonna, you know, throw a fit every time you come near them, that's a harm. So, you know, look at the impact on your family to try to sort of deliver some of these things. Yes, good point. So the point was some types of supplements or, you know, off-label treatments, so-called treatments, can disqualify you from a clinical trial if there is one going on. So just be aware of that too. It's a good point. Thank you.
Oh, no, so I did a year mitochondrial fellowship. I did 9 years post-training, so I have a lot of training. And I would just say, like exactly what you say, there's not a lot of evidence, and I had the same things as you were just saying, so ditto.
I guess one quick thing is, if we're expecting something to work by preventing disease progression, you're gonna have a hard time knowing if it's working in a quick trial. So just keep that in mind.
Okay. I'm gonna, yeah, do you want to offer it up for live questions here?
Thank you, guys. Meg.
I'm sorry in advance. Always. And it's not an easy one, but you know, we're watching our daughter get older, and so we're thinking about a lot of the things that may or may not come. You're talking about the research that you're really excited about, and I'm gonna ask the question I ask every time, and like, how likely is it that some of these things will change the outcome of some of our kids?
Yeah, so just to acknowledge how tender that is and how tender it is to talk about this in a room. We're not talking to a room full of future parents of children with BPAN. We're talking about a room full of parents and people with BPAN. So acknowledging that your kids, your loved ones are in your family now. They're varying ages. Some of them are, you know, quite young. Some of them are 20s, 30s, 40s. It's a really tough question to answer. I will say that, you know, I never thought I'd see gene therapy in my professional lifetime. I'm 64. I've still got a good 20 years in me. But gene therapy is here, and it is freaking awesome when you've seen the diseases that it is being targeted for, and you're seeing the changes. The challenges in BPAN are really quite significant. I don't want to minimize them, but this is also an area of intensive work, not just for BPAN, but for the hundreds, probably thousands of other whole brain diseases. And so I'm gonna maintain some level of optimism, and optimism not just for the 4-year-olds, but optimism for the 8-year-olds and the 15-year-olds, and maybe the older people as well, because there's some people with BPAN get on just fine into their adulthood, and it's really only, you know, mid adulthood where they start to have additional problems. And so I don't think we should be closing any doors. Yeah.
Yeah, I want to acknowledge too. Thank you for sharing. I think that this is something, as a team of people passionate about carrying a lifespan disorder, we're going to have to acknowledge different approaches are going to help different age groups, right? And what will help an infant is going to be something very different potentially than will help a 15-year-old, a 20-year-old, a 30-year-old. And so I think we don't just need one therapeutic approach. I think we need to do lots of different therapeutic approaches to really meet the community where they are. And someday we will have newborn screening, we will have gene therapy, and it will be a very different set of questions and challenges. But right now our community is diverse, and so our treatment approaches need to be diverse too. And so I know of additional gene therapy products that are currently under investigation. So it is an exciting and growing place. And actually the Foundation for the NIH program you alluded to, I'm a PI on one of the programs that just got funded. So unfortunately not for BPAN, but we're going to use it as a roadmap to be able to do this smarter, more efficiently, and better to help all rare diseases. I think designing a trial is very different than helping a whole community. A trial's question needs to be really small and really tight. But that means we're going to need lots and lots of different ways to help. So I acknowledge that we are just at the very beginning of a really exciting but really long road.
So just another quick point. So rare diseases we used to be the orphans. I mean, I've worked in rare diseases for a long time, and nobody gave a hoot really about rare diseases unless you were kind of in the community. In the last maybe 10 years, with the NIH, I think, leading the charge, the National Institutes of Health, your tax dollars at work, the NIH created this undiagnosed disease program, the UDN. Some of your kids might have been diagnosed through the Undiagnosed Disease Network. It was a way to get people answers who didn't have answers. But the really cool thing that came out of this is an awareness it was an incredibly effective program. There's now a national network for undiagnosed disease, for diagnosing undiagnosed disease. And it's made that and the Human Genome Project, advances in gene therapy, it's suddenly pharma's sat up and taken note, oh, we can make a buck here in the rare disease world. And so there is a spotlight on all rare diseases, the community of rare diseases, in a way that there never had been before. And there's a lot of interest and a lot of work going on I was talking about the modular approach to gene therapy. There's a lot of infrastructure building, resource building for rare diseases that I also think is going to help accelerate therapeutics.
So my question kind of revolves around gene therapy, but it could also be pharmaceuticals too. I'm going to use a term that I don't really love, but I've heard a lot of people say that, oh, gene therapy will fix the individual. So I guess my question is, what could or should our expectations be of any kind of therapy? You know, is it going to fix things so that, you know, my child can now talk, or is it or should our expectations be that the disease is not going to progress or they'll have a longer life? Like, what can you expect?
So I don't think it's going to make them able to talk. I think at a cellular level, and then I try and zoom out to the human, to the person. And at the cellular level, I could imagine a gene therapy stopping the accumulation of the damaging proteins. It might be so good as to be able to do a little cleanup, but it's not going to turn those long damaged brain cells into average typical brain cells. it may be, I mean, in some ways, that what I'm describing, which you might be hearing as not good enough, would be kind of miraculous if we could even achieve that. But I'm one opinion.
Yeah, I agree. I think the way we approach clinical trials in rare diseases is oftentimes by creating staged therapies, right? First, we're looking for children that have very minimal symptoms, right? Or are very severely affected. And we see if we can move the bar in those populations, and then we start making it broader and broader as we do more and more trials. But I think the chances of reversing injury are lower if you think about it from a neuron perspective, but we may have clinical trials that could very meaningfully change maybe attention or seizures or the digestive tract. And so if you start to think about sleep, yeah, thank you, I agree. And so if you start to think about what our priorities are as a patient community, we need to listen as people that design clinical trials to what really would be meaningful. And again, depending on the age, the stage of the disorder, how far along you are, your goals are going to change. And so you may have a very different idea of what a meaningful outcome for a trial is going to be. And so we need to adapt as a community to listen to families, let you tell us what's important, and then we design the clinical trials around that.
Sort of speaks to your point, actually to both of your points, I think, that there's this, can we fix BPAN before it starts? It starts kind of before the child's born, so we can't probably fix that. Can we stop it progressing? And if that could be done early enough, could you allow if you could halt this waste disposal problem in its track, wouldn't that be great? Then for the young enough, we call it plastic enough brain, the brain that is still developing in a very powerful way, could we allow normal developmental processes to have a bigger role? Because right now, normal development and autophagy of BPAN are sort of competing with one another, and that is, that's what the result is. But then there's this concern that I think everybody that has had the experience of having their child diagnosed with BPAN, kind of after they've sort of made their peace and come to, adore this child, this beautiful person, as you said, who is their person, then they learn, oh my gosh, there's this other future, and that is so, so, so hard. I've watched every family struggle with that. It is so hard to get that diagnosis, because it is not just getting the diagnosis for what's wrong right now. It is telling you something about the potential for that child's future that is not what you were expecting. There may be a second wave of anguish for you, and I know that that is heartbreaking. However, that's where I think the hope is also. And I will reflect on this experience very recently of sitting with our pathologist, all of us in a room, looking at this amazing gift that an adult with BPAN, their family, gave us to enable us to, they donated their brain, and almost just like that, we sort of reframed our thinking a little bit about BPAN. So I will tell you that when we first started, I was sure that this was going to turn out, before we had any brain tissue to look at, I was sure that that synuclein, that bad protein in Parkinson's disease, was going to be the major part of the story. And we now know that it probably isn't. And so I was on this whole track until really recently so Parkinson's research is coming along with anti-alpha-synuclein, the bad protein therapies. And that is going to be a major player in BPAN. And what I learned just in the last couple of weeks is, maybe that's actually not the most fruitful direction. It might play a role, but now, we should be looking to anti-tau approaches and what is going on in the Alzheimer and what we call the tauopathy fields to have therapeutics that could slow progression. And then the question becomes, when do you start it? Do you start, if we had an anti-tau therapy today, do we start it like in a newborn? Do we start it in a 3-year-old? Do we start it in a 7-year-old, in a 15-year-old, in a 20-year-old? And what plays into that is how toxic is the therapy? What's the pluses and minuses? But that is what is coming. I think before gene therapy is going to be like changing the course of BPAN from the get-go. I think it is going to be understanding some of the biology and some of the work that is going on in Alzheimer's and probably in Parkinson's disease and in these other related tauopathies, we call them. That work is further along, and it is going to benefit what happens in BPAN. So if you want to take away a message of hope, qualified hope, but hope, I kind of want you to hear that and to speak to the gift of giving us your cells, giving us your skin, and beyond.
Okay, my question is around, as I see development of artificial intelligence research, specifically in the medical field, it has attracted more investment than any other part of the economy over the last few years. I know that there's a lot of skepticism around what AI is, it is not, and there's even people talking about cautioning us about what it could mean in the future. But from your point of view, can you give us your opinion on how AI could help you guys in the research that lies ahead? And that's basically the question.
Can I just, I do have an opinion about this, but it's, I'm open to the possibility that I'm 100% wrong. I actually think I think it is going to help us. I think we don't know today how or how much it's going to help us, but I am interested, we're interested, the BPAN scientific community is interested in exploring that. So it's a very good question.
Yeah, I think it's a fascinating question, something that technology outside of medicine has advanced much faster than we have in the medical field. We are starting to use AI approaches to help with natural history studies and language processing to do faster, smarter natural history studies across a wide swath of hospital systems. So you're looking for the patients that maybe weren't diagnosed appropriately using AI, looking for very discrete patterns that are characteristic for a disorder that is oftentimes missed. And so I think that is one, from my view, an easy adaptation of how AI is going to revolutionize the rare disease space is by that phenotypic expansion, but also being able to collect a community of people who may not have realized that there was a community out there, and reaching families that aren't able to travel to the really big institutions that have seen many cases of something. And then also developing more intelligent clinical care and management, right? So I think artificial intelligence is ultimately going to help us distill the fire hydrant of information we're trying to drink from as medical providers. In the 10 plus years I've been in practice, it has revolutionized, but not necessarily in an easier way. We now get so much information, pulling out what's important and what's not important, identifying early sleep issues, seizures, EEG reading, to pick out subtle things. So I think AI in 5 years, maybe 10, is going to revolutionize what we're doing, but I think we're just in the beginnings of figuring out how to use it on a research setting. But I think it'll ultimately help clinical practice too.
No, I don't want to cut off the questions, but I did want to make a little plug for samples. So we are collecting research samples here. There's a room across on the other side of the elevators. We're particularly interested in samples from people with BPAN, in samples from healthy siblings. We know that that's a tough tough sell. We understand that. And we're interested in samples from young, healthy parents. So young is anything under 64. No, young is by my definition, arbitrarily, admittedly, 35 or under. We're asking for a kind of a sample way over the hill. So sorry, I didn't want to cut off.
Hello. My question is related to neuroplastic therapies that help improve functional ability. I read a wonderful book that went deep on some inspiring therapies, including light therapy, which is currently used in the Alzheimer's community, including music therapy, an Atmaniel method, which is based on Feldenkrais, a PONS device, which delivers electrostimulation to the tongue to help with neuromodulation. I was incredibly inspired, and I'm thinking about my son with BPAN and how we can help his functional abilities, and wondering if anyone has any experience or thoughts on these neuroplastic approaches.
I have no informed opinion, but I'm all for it, is my answer. And that's easy for me to say because I'm not going to be administering the therapy, but you know, you or your family or the people around you will be. I think stimulation, so I always say for kind of newly diagnosed families with a kid with any of the NBI disorders, the best therapy for your kid is a sibling. So I'm not necessarily encouraging them to have more children, but it's like play, it's stimulation, it's new experiences. And so I think those things that can give you new experiences are intrinsically therapeutic.
And it's motivation. So I think those siblings motivate. So we know that passively doing things doesn't really do anything for neuroplasticity, and actively doing things does. So there are a lot of therapeutic approaches that are built around that. Like for kids who have just one arm that isn't working well, we constrain the unaffected arm to encourage them to use that. And we see changes in the brain. We see that plasticity when they actively use the affected side. So that active engagement is really the key. And then practicing. So not just putting somebody through the motions, but motivating them to try, and that trying is what builds those brain connections. So the systems that do that involve families, parents, their environment. It's not just putting somebody in a clinical setting and moving them around, right? So, and you need therapists who kind of get that and understand that.
Oh, I feel like I'm jumping into the fire here with this answer. I feel the same way with the more intensive therapy options that are out there, that sometimes these approaches are helpful temporarily, but you really need to sustain and do it, right? So if the stimulation is helping a certain area of the brain, the moment you stop it, that benefit disappears. And so I think to my families, I tend to more encourage, okay, well, let's think about what's a more sustainable way we can increase therapeutic services, a more sustainable way we can do this, because a temporary benefit is temporary. And I think that that's where I sometimes challenge. If a family is really on board with it, I'm okay with it, but is that money, time, effort that could be going towards something that has a little bit more evidence behind it? That's where I sometimes struggle, where maybe paying for an additional, augmentative communication device instead has a little bit more evidence behind it. It's the kind of place where we don't know. It's on the fringes of medicine, and so it's hard to say absolutely yes or no to any of those things, but we do have other therapeutic approaches that do have more evidence. So as a traditional medicine practitioner, I do tend to suggest the things that I know are a little bit more sustainable and have better evidence behind them. Understanding I don't know everything. How about that? Did I step into the fire too much with that one?
I just wanted to mention that we, when planning this conference, we were very eager to to want to know what our families really wanted to know about. And we know that alternative therapies were big in the BPAN community. And so we are offering feeding therapy on Friday as well, music therapy, and also on Sunday we are having a reflex therapist come and talk. So that speaks to your question. So I just wanted to let you know that those are available.
Two comments. Actually, Penny was suggesting I give a plug to the Space Cadets, but you saw for kids, the care facility over there is being run by occupational therapy assistant students. So go over and visit them if you haven't, even if you're an adult and you're not shy about being a child at heart. The other thing is, so we are here. Most of us are here for at least a few more days. And we're eager to meet you and answer your questions. We do have, we're collecting research samples, and I'm actually like literally doing something in the room. So I'm gonna sort of beeline out of here, but it's an invitation to come and talk to us afterwards. Penny will be here for days. These folks, I think, will be here for a little while at least. Feel free to ask us questions,
okay.
But later.
Dr. Hayflick got, with the help of one of our parents who is a medical provider here in the state of Texas, a 3-day Texas medical license to be able to do some of these procedures. Actually, the applause is for the parent who sponsored her, which is hilarious. But it was a big deal, and so we're going to be pretty focused. I mean, it's such an amazing opportunity to be able to get some of these samples, and it will give us, you all have helped to fund this research repository. We share our samples with researchers around the world. We can do, we're providing this amazing library of samples, and some of these things we can only do with the samples that you yourselves, your child, can provide us. So big plug, and thank you in advance.
Okay, thank you guys. I know we ran a little long, and I know there were more questions, but I encourage you to pull them aside, as they said. And they're headed over to do the samples, and I suggest you guys try to head over there too. Thank you very much for your time and all your efforts.